Perfect. So very much a hard pivot from the last talk we heard, but that was an excellent talk. I'm jealous of whoever won 1 year of financial planning. So for the next 20 minutes, I'm going to discuss immunotherapy and lung cancer. It is a giant topic, and so I'm hoping to prioritize the key points. And so these are my disclosures. And so the agenda for the next 20 minutes is really twofold. First, we're going to describe the evolving role of immunotherapy for management of non-small cell lung cancer. And so the emphasis here is non-small cell lung cancer. Dr. Roto is going to talk about small cell next. And I think the important or most pertinent part is that we're going to discuss the applications across disease settings. And it's really fun that I can say that now, because if I gave this talk 4 to 5 years ago, the only disease setting was really metastatic disease. And then we're going to briefly review current understanding of resistance to immunotherapy in lung cancer. And so this is an evolution conference. So I did as much as I could to kind of integrate these types of evolution themes throughout. And so the first thing that I think is not a focus of this talk, but I think is always important to mention when we're talking about thoracic oncology and lung cancer, is that as we think of a lung cancer going from a stage 1 to a stage 4, there's a couple of kind of acquired traits that happen, right? You have increased metastatic potential, you get increased biological and molecular heterogeneity. This leads to, by definition, metastatic disease has a larger tumor burden, and that can translate to increased symptom burden. And so the overarching goal of all thoracic oncologists is really to intercept or eliminate the cancer before it develops these adaptive and refractory traits, right? We want to intercept, we want early detection, and so lung screening remains kind of the central tenet to what we're doing. Lung screening, unfortunately, is not encompassed currently in an immunotherapy talk, but I think it should still be at the forefront of what we're thinking about doing as a thoracic oncology community. With that, I will turn towards kind of the task at hand in terms of describing immunotherapy in the modern era. And so I've borrowed this graphic from a publication by Dr. Reck and colleagues in JCO last year. And so this is summarizing approvals by the EMA and the FDA of immunotherapy. And Dr. Reck actually begins his timeline at 2016. I will say that the origin story for immunotherapy approvals in lung cancer doesn't really start in 2016. It's probably a year before, where we had kind of the indication post-chemotherapy as a salvage strategy. I think it's worth noting that, but I agree, kind of the modern era immunotherapy as the cornerstone of treatment really begins in 2016 with these studies. And what I hope to do as we go through the upcoming slides is really emphasize that we have a couple of different paradigms, right? So there's immunotherapy monotherapy, there's immunotherapy plus chemo, and now we even have checkpoint doublets. And so let's start in 2016. This was a pivotal and groundbreaking study at the time in that it allowed us to have a chemo-free approach. And so this is Keynote 24. It randomized a selected population of patients. So these are patients with PD-L1 high tumors defined by the cutoff of 50% to either receive pembrolizumab, which was a chemo-sparing approach at that time, versus the historical comparator, the historical strategy of platinum doublet chemotherapy. A couple of key points. So this wasn't kind of a random study, right? It was informed by phase 1 and phase 2 studies that told us that having high PD-L1 expression was predictive of benefit from immunotherapy. And then if you look at the key eligibility criteria, they excluded patients with EGFR and ALK alterations because we also had studies that tell us that certain populations don't really benefit from this approach. These are patients with minimal or no smoking history and those who have EGFR and ALK alterations. And so you'll see this as a recurring theme as we go throughout the slides. And so we have now seen lots of follow-up data, so 5 years now, that show that this was a winning strategy, right? So there was a doubling in median overall survival from about 13 to 26 months. And importantly, a number that I quote my patients when they ask me is that at 5 years, 1 in 3 patients is still alive with this strategy. And so that led to the approval of that regimen and kind of informed our current therapeutic paradigm for patients with metastatic, so this is still metastatic, PD-L1 high non-small cell lung cancer. And so this finding has been substantiated and replicated by multiple studies using different PD-L1 and PD-1 inhibitors, including pembro, which we talked about here. We've also seen atezolizumab and cemiplimab. I should note that there was a study that was similarly designed with nivolumab, but it was a negative study, I think perhaps due to patient assignment and design and other things. And so this is somewhat of a busy slide, but just really to articulate that overall survival is improved across all of these studies with the exception of the top one. And so this is an easier way to digest the data. And so this is a table summarizing the studies that led to FDA approvals for the specific indication is monotherapy in the first-line setting for metastatic non-small cell lung cancer. What you see from this table is that we have pembro, atezo, and cemiplimab approved for PD-L1 high tumors. And pembro does have a little bit of a unique distinction in that it's approved not just at the cutoff of 50%, but also at 1%. And that's based on the KEYNOTE-42 study. But I will say that if you ask me and my colleagues, it's not often that we're giving people this for PD-L1 1%. And that's because if you really look at the subgroup data, the benefit is really driven by that PD-L1 high group. But it is an option if someone has a PD-L1 1% to 49%. And so I did want to highlight this study from ESMO last month. And so we often meet patients who may not have the functional status, or they may not have been the age to be kind of encompassed in those studies that we referenced before. And they may not be chemotherapy candidates, but hospice seems like not the right strategy either, right? There's still a treatment option for these patients. And before studies like these that kind of look at it in a prospective fashion, we were kind of doing what we preferred in this setting. And so I think this type of trial is important. So this is a study that took that population of patients, those with borderline performance status, those who may have been a little bit older, and randomized them 2-to-1 to receive atezolizumab or single-agent chemotherapy. Key distinction between this study and the ones that I discussed before is that patients were not PD-L1 selected, right? You didn't have to be PD-L1 high. The primary endpoint was overall survival here. And what we see is that, median progression-free survival with atezolizumab versus single-agent chemotherapy was nearly identical, but there was an improvement in median overall survival. And importantly, among the patients who have a response to the therapy, be it chemo or be it immunotherapy, the median duration of response was quite a bit longer with immunotherapy. This is a trend that we see across studies. And so this is an opportunity to treat a population of patients that was not encompassed or captured in the earlier studies. But as mentioned, most of us, when we see a patient who has a non-small cell lung cancer with a PD-L1 less than 50%, we're not really reaching for immunotherapy in the first-line setting. And that's because our paradigm was really set by studies like this. So this is KEYNOTE-189. This is a non-squamous cohort, and there's a kind of a corresponding study called KEYNOTE-407, which is an identical study design, but a squamous cohort. And this was exploring a different question, right? So in PD-L1 high tumors, the question was immunotherapy monotherapy versus chemotherapy doublets. In PD-L1 low tumors, it was, can we have an additive or some sort of synergistic effect if we add chemo and add immunotherapy to chemo versus chemo alone? And so that's the study design here. And the answer, and kind of the short answer, is yes. So there was, again, a doubling of the median overall survival from about 10 to 22 months here. And last month, we actually saw the 5-year follow-up data, and we see about 20% of patients are still with us at 5 years. And so this, again, is capturing and kind of illustrating the point that there have been multiple studies. So pembrolizumab is great, but it's not the only thing that has shown this benefit. Multiple checkpoint inhibitors have shown this. And so we have approvals with atezolizumab. And then there's studies conducted in Asia that have looked at other drugs like sintilimab, tisli, camrelizumab, and others. And so that was non-squamous. These are squamous studies that show the same trend, really substantiating and validating the point that, for patients who have PD-L1 low or negative tumors, the addition of immunotherapy to chemotherapy is superior to chemotherapy alone. And that really is how we treat patients that we meet in clinic who fit that characteristic. And this is a table really summarizing that. And so in the US, our options really are pembro and atezolizumab-based combinations. That may change in coming months because there's been other promising studies in this setting. I do want to highlight for the atezolizumab studies, they usually use a taxane backbone, and there is an opportunity to fold in VEGF targeting, so Avastin or bevacizumab here. And so many options to choose from, and we use PD-L1 as our cutoff for the metastatic setting. I do want to spend a moment, because so far I've talked to you about immunotherapy, monotherapy, and the combination of immunotherapy and chemotherapy. But there's also an alternative approach that's kind of at our disposal and kind of available. And so that is the doublet of Ipi-Nivo. We see that in melanoma, we've seen that in mesothelioma. It's also available for non-small cell lung cancer. And it's been explored in 2 different regimens, the first being Checkmate 227, which is a very complicated study design, which we'll look at really briefly in the next slide. but it looked at patients according to PD-L1 status, metastatic non-small cell lung cancer here, and randomized them to receive Ipi-Nivo versus chemotherapy, and showed an improvement in median overall survival with Ipi-Nivo, irrespective of PD-L1 expression. But because of the way the statistical plan was spent, the FDA approval actually only applies to PD-L1 expression, so expressing tumors with a cutoff of 1%. Checkmate 9LA is a little bit of a more interesting treatment regimen in that it's based on the premise that if you look at the earlier studies that looked at immunotherapy in all comers, in the initial 3 to 6 months, you see a rapid drop-off in patient survival, suggesting that there's a subset of patients who's really not benefiting from that approach and passing away quite quickly. And so the question is, does it take a little bit more time for immunotherapy to work for some people? And can we protect those patients, improve disease control rate in the initial months of treatment, and then let the immunotherapy kind of do its work? And so the rationale for this study is, or the design of this study is 2 cycles of chemotherapy overlapping with Ipi-Nivo. And this again was a positive study, improvement in median overall survival, irrespective of PD-L1 expression. And so the indication encompasses all PD-L1 subsets. And so this is the study design that I was talking about for both of these, 227 and 9LA. As you can see with Checkmate 227, the Ipi-Nivo study, there are 6 different arms. And so it's a very complicated study. And so that was a quick tour through stage 4 non-small cell lung cancer. But the second indication for immunotherapy in non-small cell lung cancer was the stage 3 setting, an inoperable stage 3. These are patients who have cancer involving their mediastinal lymph nodes, but perhaps those on the opposite side from the lung cancer, those above the clavicle, supraclavicular lymph nodes, or maybe they have multiple lymph nodes that are on the same side as the tumor. And so the surgeon thinks it's going to be hard to remove that cancer. These patients are traditionally treated with what we call definitive chemoradiation with curative intent. And so this study, which was presented several years ago now, asked the question, can I improve outcomes if I add 1 year of durvalumab after someone has completed chemoradiation? And the answer is yes, you can, right? So it improved median progression-free survival by about a year and improved median overall survival by about 1.5 years. And importantly, I like these landmarks, right? These 5-year landmarks. So importantly, if you look at 5 years, over 40% of patients are still alive if you add the durvalumab versus about 1 in 3 if you don't. I should note that there may be differential efficacy or benefit depending on certain subgroups. And so again, not every single person's tumor had PD-L1 expression tested, but in the subset of patients who had PD-L1 negative tumors, they didn't benefit as much. So that led to distinctions in the approval indication in the US versus Europe. In Europe, it's not approved for PD-L1 negative tumors. In the US, it is. And what that means is that as a thoracic oncologist, I have a more nuanced discussion if I have a patient with a PD-L1 negative tumor about the pros and cons of durvalumab. And so I think most of the excitement in recent, kind of the last year or so, has really been in the early stage setting, right? First we started with immunotherapy in stage 4, we moved it to inoperable stage 3, and now we're talking about using it in patients who have resectable lung cancer. And the first study that made inroads towards this strategy is Empower-010, or the first kind of published one that led to an approval. And so this encompass patients who have had surgery. They have tumors that meet criteria for adjuvant chemotherapy, which is really, we consider it when a tumor is greater than 4 centimeters. And so the idea is that they would have surgery, they would have chemo, and then they would get randomized 1-to-1 to receive either atezolizumab for 1 year or best supportive care. The primary endpoint is disease-free survival, so RFS, disease-free survival, and in a hierarchical testing design. They looked in PD-L1 positive stage 2 to 3 first, then all stage 2 to 3, then all people who met that kind of 4 centimeter cutoff criteria, and then looked at overall survival. So the punchline is that this was a positive study for disease-free survival. There's a hazard ratio of 0.66 in that PD-L1 positive stage 2 to 3 population. And as you start expanding, you lose some of that, that benefit, right? So the hazard ratio then drops off to 0.79, and then it wasn't even significant when you go to stage 1B at the time that they analyzed the data. And so this led the FDA to approve this regimen for PD-L1 positive, so that 1% cutoff, stage 2 to 3 non-small cell lung cancer. We've subsequently seen the data from this study being presented according to subgroups, and it does seem pretty consistent with our metastatic setting that a lot of the benefit is derived when you have a PD-L1 high tumor versus a PD-L1 low tumor. And in a preliminary presentation of overall survival, similar trends were holding as well. And so this is one that is kind of asking the age-old, the study design is not necessarily asking it, but it's inviting the age-old question. Is it better to give treatment as a neoadjuvant strategy or an adjuvant strategy, right? There's advantages to each approach in a way, but neoadjuvant really lends itself in a practical sense, right? So after going through chemo, I guess after going through surgery, there's a recovery period, right? It's hard to give chemo in that setting versus giving it up front. And at the same time, if you think about the biology of the immune system, it may behoove us to give a therapy when you have a big kind of neoantigenic burden. It's easier for the immune system to recognize that. And so that's some of the premise for thinking about these neoadjuvant strategies. And so the most relevant neoadjuvant immunotherapy study, as far as our therapeutic landscape, what can I prescribe now, is Checkmate 816. This study took similarly the patient population that we think about chemo after, that we think of as curable, number one, and we think about chemo after surgery, and randomized these patients in the upfront setting to receive chemo plus Nivo for 3 cycles versus chemo alone for 3 cycles followed by surgery with the primary endpoints that were dual, right? 2 different primary endpoints, path CR and then event-free survival. Path CR means no viable tumor cells when they look at the resection bed as well as the lymph nodes. And so here they saw an improvement in both path CR and event-free survival. So with chemo alone, path CR was 2% versus 24% when you add the immunotherapy, and event-free survival was improved from about 21 months to 32 months. So there's a lot of enthusiasm about this study, and this was seen irrespective of PD-L1 expression, and so this is approved without a PD-L1 threshold. And I would honestly say that in my clinical practice, I do tend to think about the neoadjuvant strategy over the adjuvant strategy when I can. And so revisiting our evolution theme, if we're thinking about kind of the evolution of the therapeutic landscape or clinical application of immunotherapy in non-small cell lung cancer, we've really actually gone from like the most advanced stage and we're walking our ways backwards. I will note that there's Stand Up to Cancer efforts that are actually looking at pre-invasive lesions. Is that a good opportunity to use immunotherapy to engage the immune system and prevent these from even ever becoming cancers? And so I think that's a direction to keep an eye on. And so, as mentioned, a component of this talk was going to be talking about biomarkers that help us predict who might benefit from immunotherapy. We've already mentioned 2 of them. One, PD-L1 status. That's our most consistent predictive biomarker in non-small cell lung cancer. And we know that it's a dynamic one, right? And it doesn't tell the whole story. We do know that those who have very high PD-L1 expression or whose tumors do, greater than 90%, have the most benefit from immunotherapy. But we also know that many of those patients will relapse after immunotherapy, so we need better biomarkers. I've also mentioned that EGFR and ALK are negative predictors, right? Patients are less likely to benefit from immunotherapy in that setting. Another category of biomarkers that has become relevant based on multi-center efforts is really KEAP1 and STK11 mutations. These are negative predictive markers. Patients who have these don't benefit as much from immunotherapy. And we used to think that it didn't matter, right? If you find one of these, it was a negative predictive marker regardless. But there's work led by the Dana-Farber group in a multi-institutional cohort that really shows that if you have a KRAS mutation and you have a KEAP1 or an STK11 mutation, you're less likely to benefit, or you're more likely to have a shorter duration of benefit from treatment and shorter survival. And that's not necessarily the case in the absence of a KRAS mutation as we see here. And that's the same story with STK11 mutations. And so if we see a KRAS or STK11 in the context, we see a KRAS mutation with a concurrent KEAP1 or STK11 alteration in the context of immunotherapy, this is someone I'm going to keep a closer eye on their clinical symptoms. I'm going to have a lower threshold to restage and think about alternatives in clinical trials for. And so I think one interesting thing to highlight here is that that was kind of intrinsic resistance, right? Primary resistance to treatment. We know that patients respond to treatment and ultimately develop resistance afterwards, and so this is acquired resistance. This is a cool study that was presented at ASCO this year by the Dana-Farber group that showed those same STK11 mutations, sometimes they come after someone has already received immunotherapy and they may be driving acquired resistance. So I think it's worth noting that. And so I thought, this is a tale of two women, right? Just to really emphasize how much progress we've made, so give us an opportunity for celebration, but telling us how humbling this disease is. And so these are two patients of mine. So the first is Peggy. She's 70-something years old, PD-L1 high, my first 100%, with lung cancer metastatic to the brain. She was on dialysis for several years when I met her. She was diagnosed in 2017, had a solitary brain met, got it resected, has SRS, and then started Pembro in 2017, soon after its approval. She had a complete response at 2 years, and she continues on treatment now, has no evidence of disease. I see her every 6 months, and she's doing well. So this is a cause for celebration. But let's turn the coin on the head, right? So this is Joan. Joan and Peggy, I met around the same time. Joan is also 70-something. She also has a PD-L1 high tumor, 70%, metastatic to the brain, and she also presented with a seizure and a solitary brain met. And so she also had brain resection, SRS, started Pembro, had an isolated recurrence in the cervical spine, the cervical node that was resected, no evidence of disease for a long time, and a few months ago she developed nausea, vomiting, and headache and has a recurrence of her lung cancer. So this is a sobering story, right? I would have thought that maybe she was the tail of the curve. And so we still have our work cut out. And so in summary, I think the key points I would like to make today is that we've come a long way in terms of the evolution of the application of immunotherapy in non-small cell lung cancer. Used to be something we reserved for a salvage strategy after someone had progressed on chemotherapy, and that was really the cornerstone of our treatment for both metastatic and early stage disease. We do get durable responses, but we're not curing most people with it, and so there's an opportunity for combinations and other strategies. We have a few biomarkers, including STK11, KEAP1, and PD-L1, but there's an incredible opportunity to develop additional biomarkers. And so with that, I will thank you and do I take questions now or after? Okay, I can take questions.
Hi, thank you for the talk. In the last examples that you gave, you stopped the immunotherapy. What is the thinking on that? How long you can do it? I know I've heard different things on that, and I guess your case studies show that who knows when you should stop or if you should stop.
Yeah, I think this is something that comes up a lot, right? And so do you even do imaging before you stop? Some people say I do a PET and that informs me. If you're someone who follows the study design, you stop at 2 years, right? And we don't have great studies to tell us how long patients should continue on. And some people say if you continue for a long time, you're exhausting the immune system. But I'll have to tell you, in reality, when you're facing a patient who has been on the treatment for 2 years, some people don't want to stop. And I think it's a very tough conversation. And so I'm starting to kind of prepare people at the beginning that the idea is to stop after 2 years, but in all honesty, there are some people I continue beyond that. I think a cool or interesting thing is that we saw recent data at ESMO last month looking at 6 months versus 12 months, and 6 months didn't seem any worse than 12 months, and it was just less toxicity. And so I think that we're going to need these studies in a prospective fashion to inform things, but I also, at the end of the day, I think it's going to be the patient in front of you that's going to help dictate that, and the disease status, right? If someone has a complete response, had some tough time with immunotherapy, I'm more kind of willing to stop that therapy then. If there's residual disease, they've tolerated it well, and they really want it, then I will probably go to bat with an insurance company to try to get more of it.
For patients who have had adjuvant or neoadjuvant immunotherapy, and when they recur or become metastatic, is there a role again for immunotherapy if they're this is not my area of expertise, I'm just curious.
Yeah, I think it's a tough question. And I would say that one thing I didn't talk about in the neoadjuvant study that I presented, there was an opportunity, and this is why people are excited about neoadjuvant, right? You get an early readout of how well your treatment worked. And so if someone doesn't have a past CR, they have a whole bunch of gross residual disease, there's an opportunity to give additional outback chemo. And in that study, about 19% of people did. And so, but the question is, what would you give? Another time we faced this scenario is that Durva situation, right? After 1 year of consolidation durvalumab, if their cancer relapses, do we then go to our chemo plus immunotherapy strategies? And I say I tend to, unless they are relapsing within a few months of stopping the durvalumab, in which case I'm not sure it's very helpful. I think the interesting thing is that cemiplimab, one of the other drugs that has that first-line indication, they have looked at the findings after adding chemo in someone who's relapsing in that setting. And I think we still have to see what that data show, but if someone is tolerating it, I think that we don't have a lot of prospective data to guide us, and I think personally, I do tend to continue the immunotherapy and add something to it. unless they had toxicity or they relapsed very quickly after having the immunotherapy in the earlier stage setting.
Thank you for a really excellent talk. I have been particularly interested in the neoadjuvant trial, so Checkmate 816. Whenever I give neoadjuvant treatment, one of the discussions that I like to have up front is if you have a pathologic complete response, we still need to talk about surgery. And so for a lot of my patients, that is a really difficult discussion. And so I noticed in the trial maybe 15–20% did not have surgery. What would you do in that setting? How would you manage those patients?
Yeah, I think that in some ways, right, and so it's two different paradigms in some ways, right? So rectal cancer, colorectal cancer, and all of them, where this comes up a lot, right? Where if you get an excellent response in rectal cancer, they don't necessarily want you to do the thing that is associated with more morbidity, right? In non-small cell lung cancer, it's often hard for us to tell the depth of pathologic regression without doing that big surgery. And I always kind of remind people, like, the best way to be cured of your cancer is to physically remove it from your body, right? Otherwise, we're just guessing what's left on scans. Is this active disease? Is this inflammatory cells? Is this scar? And the story's not clear until a bit later. I think one key thing, though, is that as our tools are advancing, we're going to have ctDNA, we're going to have other things to guide us about who needs more therapy and who we can actually PSI, right, after they've completed that therapy, who has the best chance of being cured.
Thank you so much.